I am delighted to be joined in conversation with Denise Johnson, the Deputy Lead Nurse in Aberdeen Health and Social Care Partnership. Denise, it's lovely to see you today, and I'm so pleased that you've taken the time to have a conversation with me. I know that you're nervous, and I know that there had to be some negotiation to get you to do this. So really looking forward to just having a blether with you, to hear about the work that you're doing, particularly interested in the hospital at home work and understanding some of the experiences that you and your colleagues have had over the past couple of years. So Denise, if we start off just by you explaining to colleagues that are taking the time to watch this conversation, tell us a bit about the role of the deputy lead nurse and maybe even the typical day, and what were the kind of decisions that you made that took you into that post, your career pathway and type things?
So thanks, Caroline, and morning, and thanks for having this conversation with me. So yeah, the deputy lead nurse role in Aberdeen City, I'm one of 4 deputy lead nurses,
Okay.
and my 3 other colleagues, they are all deputy lead nurses for specific localities, and within each locality, they're responsible for the community nursing teams, the health visiting and school nursing teams within these localities. My role differs slightly in that it's the deputy lead nurse role for citywide services.
Okay.
And that includes hospital at home, it includes stoma nursing, city visiting, the healthy house, out of hours, liaison. So there's a wide variety of services, and I hope I haven't forgotten any of them in that list.
We'll come back to that if you have.
So the typical day, I guess a typical day consists of lots of meetings. It consists of reacting to things that come up in a day. We have responsibility for the professional nursing issues. We have responsibility for operational issues, for service management issues. So it's a very holistic role where other specialties may have a nurse manager and service manager, etc. I guess it's all wrapped up into the deputy lead nurse role.
And Denise, we worked many years ago when you were a nurse manager in ERI. And for budding deputy lead nurses out there, can you tell us a bit about what it felt like to move out of secondary care into community, and your career pathway to become a deputy lead nurse?
Yeah. Well, I guess I had been a nurse manager in ERI for a number of years, and to be honest, I'd guess I'd worked in ERI most of the time that I'd been in Aberdeen, and I'd had various roles within leadership development, practice education, clinical leadership in the RCN, and a lot of the skills and qualities, I suppose, that I developed over the years provided me with that rounded knowledge and skills required for a nurse manager, but certainly for a deputy lead nurse, I think you require a lot of variety of skills. It's not just clinical knowledge, for example. So, but the move from secondary care to primary care or community was one. I guess it came about because we'd often spoken about hospital at home some years before, and suddenly this post came up, and it was at a time where I'd had a variety of nurse manager jobs. I'd worked in different specialties across the ERI, and I thought this would be a real challenge because it was setting up a new service. It was a new model of care. There weren't many areas within Scotland at that time delivering hospital at home. So there was lots of reasons why I chose to, I guess, move across from secondary into the partnership, and one or two people had often been asking me to move into the health and social care partnership, and that was the right moment for me, and that was into the team lead role for hospital at home to set up the service. But coming into the deputy lead nurse role, that was in towards the end of 2020 that I took up this role. And I suppose that came about part and parcel because of COVID, because of the changes to my role that were taking place. Like many people at that time, we were being asked to do different things and new things and do things differently. And I guess that was one of the I suppose the drivers for me moving into this role.
So Denise, you mentioned there about that being asked to do different things during the pandemic, and really interested in hospital at home. And I'm sure it would be great to get a bit more of an understanding about where that's at and what you and colleagues that are working on that pathway have as an ambition. So really two questions. One is about, so what are the things that you and the team have been doing differently? The good, bad and the ugly around that. What's it felt like to be a nurse working in all the areas that you've covered? And then we can talk a bit more about hospital at home. So yeah, about you and your colleagues during the pandemic. What are some of the things that you think we should look back on that and continue to build that and be proud of it? And what are some of the things that you think we really need to learn the impact of that?
Yeah. I suppose when I think back to the start of the pandemic, and I was still in the team lead role for hospital at home, but I also managed the community geriatric nurse service and the city visiting team as well, which was the urgent care practitioner service. And unfortunately, I was one of those people who, at the outset, was asked to work from home. So I was at home for the first 3 months of the pandemic, and that was really challenging because as a team lead, as a manager, you want to be in there with your teams, being visibly supportive. So trying to do that at a distance when we didn't have Teams, MS Teams at that point initially. I think we were a few weeks into the pandemic, certainly before we had access to MS Teams. So that was really challenging to support, direct, encourage and change ways of working initially. And I think the teams found that difficult, and one of the teams that was pulled into the COVID hub that I managed, again, that was a challenge for them. They were suddenly not doing what they were employed to do. It was very different. So it was for me, it was about trying to support people at a distance. And now we're used to doing that, but we've been able to do that because we've got MS Teams. So I think looking back, it was really challenging for individuals within the team and within the hospital at home team, where for me, I was trying to keep an eye on the ball that actually there was a lot of focus on COVID and COVID in the hospital setting, but actually what about unscheduled care presentations that were non-COVID, and what we couldn't afford to take our eye off the ball there. So I was trying to influence a lot of work around how do we take that forward, not just the COVID work. And I guess out of that, there was a lot of work done around the stepped care approach within Aberdeen City. That had been an ambition of ours to develop a stepped care model where we can readily increase and decrease the level of health and care input for patients in the communities without having to have so many handoffs that we traditionally would have had, always going through GPs or in and out of hospital, etc. So that actually, a positive from the pandemic was expediting that work that we'd initially started talking about in 2019. So and then other services that I managed, again, being pulled into wards and etc., and cancelling their services and temporarily cancelling services and moving people around. That was really difficult and challenging, and people initially were very understanding and willing to do so, but I think as time went on, that it was really difficult for people, and they wanted to know when we were going to get back to my actual job and my actual service and such like. And so that's not only been difficult for them, but it's been difficult for their patients, regular patients that might access their services and such like. So it has been challenging for everyone all round.
And I think you've not said anything, Denise, that I haven't heard from other colleagues, and the scale of change. And you spoke about working. In fact, I'm struggling to remember a time without Teams, actually, but you're right.
Mm-hmm.
So the scale of change, working from home and all the consequences of that, and the deployment has been really challenging, I think. And you're right, people were supportive and recognised the challenge at the beginning, but we're now 2 years into that, and that remains a very difficult, as it would for any of us, to work away from our team and the specialty that we've joined the organisation to work in. And I'm also glad to hear, however, that it has created opportunities. And you've mentioned the stepped care model that you've been trying to implement. And I suppose the digital teams work and the links between primary and secondary care, I've heard positives and negatives about that as well. So what are some of the things, particularly relating to hospital at home? Because I know that's a conversation that I'm involved in really regularly, around, in particular, the frailty pathway, Denise, and the opportunities that we've now got as we hopefully move forward from COVID. What, from your perspective, are the opportunities for the hospital at home model in Grampian and the work that you and your colleagues have been immersed in for years?
So the current established hospital at home within Aberdeen City has, right, as you said, it's all been around the frailty pathway. It was designed to provide a service for older adults living with frailty, and that's, we have built the service around that. Our consultant geriatricians are geriatricians within the team, and when we started hospital home, we started with 5 beds. We didn't have medical staff input. We had multi-professional staff in the team, but we didn't have medical staff. We gradually increased to 10 beds, and then when COVID happened, we increased to 15.
Okay.
And then we got a consultant in the team towards the end of 2020. So it's very much been designed around the frailty pathway, and with the changes to Rosewell House becoming an integrated care facility and such like, and the changes at Wood End, hospital at home is very much a feature of the frailty pathway. And we recognise that, and our aim is to increase to 30 beds for frailty. So we're working on that and recruiting to the resource that we have to enable us to open up these other 15 beds for frailty. But since COVID, and one of the things that we're looking to do is to increase further our bed capacity in hospital at home, but not necessarily around frailty. There's a lot of work around developing community respiratory team, and the respiratory service in Grampian has worked hard over the last 1.5 years to make a lot of changes and undertake tests of change. So we know what will work, and we're working really hard to put things in place that will support and enable a community respiratory team across Grampian. And certainly within Aberdeen City, one of the things I'm keen to do is develop our established hospital at home service, but link it in with respiratory, because obviously being set up for frailty, our consultants are geriatricians. For a respiratory hospital at home, we would require a respiratory physician to be involved in that. But I think there's absolute value and would build the capacity if a respiratory hospital home arm sits within our established team. We would get much more capacity by utilising the team that are currently there and upskilling them across frailty and respiratory. We've got some really, really skilled practitioners in the hospital at home team with a variety of skills and a variety of backgrounds. So with a bit of education and training, we could certainly upskill those. staff there, but we definitely need respiratory consultant input, and that's, I guess that's a challenge. Workforce is always a challenge, recruiting and retaining staff, but that's certainly something where we need to be progressing, and we know that, you know, all the national work as well, we know that a lot of the respiratory, particularly COPD, there's high admitters to secondary care, and if we can put something in place that would be better for patients, better for families, and it would have such an impact on our front door services.
So Denise, it's good for me to hear, and I'm around some of these conversations around hospital at home, and it would be fair to say there's quite a lack of understanding sometimes about what it actually is, what the ambition is. And so would it be okay to make the offer if anybody, one, is interested in coming and working with you and the team around hospital at home, just to get in touch with you, and also people want clarity on understanding what the model of care is, what it is and what it isn't. Where would they find that information?
So I'm happy for people to contact myself directly, but you know, the hospital at home team are based in Wood End Hospital,
Okay.
and we have a generic email address.
Okay.
But I'm happy for people to just contact us, because we have had one or two colleagues. We've had one of the consultant physicians from ARI come and spend some time with us. So we're really keen to anyone that wants to come and spend time, because you're right, Caroline, there's something about people understanding what it is we can and can't do, and that's, we've seen that through a test of change that we did with our GP referrals. So we, in hospital at home, we take direct referrals from GPs, but GPs can also directly admit to Ward 102, which is the frailty unit. So what we did was a test of change where the receiving on-call reg or consultant in the frailty unit would take the call from the GP and actually almost triage the call and say, could you please contact hospital at home for this patient? And initially, when we proposed that to some GPs, that there was a challenge back to us that if I'm a GP and I want to admit, it's because I know that they need to be admitted, and that they were absolutely right about that. But because they didn't know what we could do, they didn't know that actually that patient could also be equally safely managed by hospital at home. So through that test of change, we were able to demonstrate that 70% of the GP referrals that were redirected to hospital at home were safely managed by hospital at home.
Okay.
So we're building on that work.
So yeah, and I think nobody would argue with the desire to provide really good care for our older population, and indeed you're speaking about patients that experience respiratory conditions and need support at different times. And also for both of those populations, the demand always feels as if it exceeds capacity, doesn't it? It always feels really pressured. So new models of care, I think, are an absolute, and building trust across sometimes what feels like that big mountain between secondary care and primary care is really important. And so thank you for offering to help people's understanding around that. One of the things that you've touched on there is just around people's ability to change and to I suppose move beyond the pandemic, and that feels really tough when people are tired and have been working really hard. From a cultural, and all I mean really by cultural are behaviours and some of the fears and anxieties that people have that prevent us changing and doing different things. What are some of the enablers that you would think we should be focusing on as an organisation to help people to do things differently? And you've got the huge benefit of knowing what it's like to work in secondary care and in primary care. So it'd be great to have your insights into whether that's culture or whatever it is.
I think one of the things that certainly for me anyway is involving the people, involving the staff, and handing things over to them and asking them what do they want to do and giving them the responsibility. Just before Christmas, we had a development session, and it was just a short session, a couple of hours. It felt at that time that it was a bit of a privilege because the pressure was on, as you know, but I felt it was something that absolutely had to be done. It was part and parcel because of feedback from patients and families as well. So we did a development session with the team, and out of that we've clarified roles and responsibilities for people to take on elements that they can develop themselves. And now, you know, I had a message from one of the administrators last night to say myself and one of the nurse practitioners are going to do a poster for the NHS event. So they've come forward to do that. So it just builds that enthusiasm, and it encourages people, giving them that responsibility and giving them that involvement. There are also people who, when you do give them that, they still shy away from it, and they do struggle with change. And how we support them is in a different way. It's trying to take things a step at a time for them. Some people want to run before they can walk, and others, as you know, will take that wee while longer. So it's difficult getting the balance right for everyone. Not, you know, it's not a case of one size fits all, I suppose.
Yeah, I think that's the real challenge, isn't it? Is 14,500 colleagues in our system, and that's 14,500 different perspectives and different needs. So how we create the right conditions to do what you said, which is for people to own the pathways with the people that experience the pathways and to shape them in a way that's going to benefit the public is a real challenge. And sometimes it's easier just to do that in a closed room, isn't it, rather than hear all the different opinions. And I think that's one of the things that some people do really well and some people do struggle with. So how do we, as you say, support them differently? Throughout the pandemic, Denise, I've been overwhelmed by some of the things that I've observed, and just how people manage to come up with solutions, and particularly in our health and care services, working with communities in a different way. I think everybody has wrapped around trying to support people and to do the right thing. Since I managed to coerce you into participating in this conversation, is there anything that you would like to use the opportunity to give a shout out to colleagues that you've worked with, that you've either examples that you've just been completely humbled by, or anything that you'd just like to say by way of thanks to your colleagues?
Yeah, and I'm grateful for the opportunity to do so, because I, as you say, I have absolutely been blown away and overwhelmed with some of the responses from staff. You know, I don't want to single people out, but there are individuals, and if they watch this, they'll know who they are. But recently I spoke with a healthcare support worker and from one of the teams who is having a difficult time out with work, and just sharing our own personal experiences, and that understanding of how, despite all of that, they come to work every day and they give 100% and more, and they are enthused and continue to be enthused to continue in the work that they do. So I'm grateful to people who, like, you know, behave in that manner. They come to work. They're there for their colleagues despite their own challenges in life. And I guess when, as a manager and a leader, you constantly want to put on a face for your staff that's a positive one and an encouraging one, and they don't know what's going on behind the scenes for you, but when they are there for you when you need them to be, again, that's been so appreciated. But I would like to say thank you to all the teams that I'm responsible for, because they have rallied, they have continued, they have flexed, they've adapted, they have supported their colleagues, they've welcomed new colleagues into teams when people have been deployed, and to those people who have joined some of my teams from other teams in other parts of the system that I've never even knew existed, and have just, you know, joined, and it's been a real pleasure and a real, yeah, it's been a pleasure to see that and work with those people, and I feel quite grateful that I've experienced that in this role. And I guess the other thing I would say is that because of the changes that we've had to make during COVID and the groups and teams that have been set up to make changes and to continue services and to continue providing services for the population, it's been a real positive experience to meet so many different people. And I think when you come together in these groups that are suddenly put together to make all these changes and to take things forward, you don't know the people, you just get on and do the job, and you each have a role to do and you get on and do it. But when you start to get to know some individuals behind that, it makes it even more rewarding, because you know what's going on for them out with, because we all have lives, we're all human, we're not just all nurses, therapists, doctors, managers. We're human beings, and we are living in a context of a pandemic as well as working to get through it. So it's been a real pleasure, I guess.
Denise, I couldn't have put it better myself, and I think as a huge system of people working for people, if we don't recognise the human aspect of that, it makes it really difficult to be compassionate and to empathise and to provide the right support. And so I would agree that the importance of getting to know people as people in our teams, and more excitingly out with our teams, is a really good step forward in the way that we behave as different parts of a really big, and at times it feels onerous, institution of health and care. So just to finish up, Denise, some really good things there about working with people that you don't usually come into contact with. Are you starting to feel some hope, and how are you going to hold on to those things that you've just described as we hopefully come out of this winter and move into spring and summer and learn to, I'm definitely looking for a better phrase, but I can't come up with one, learn to live with COVID? Have you got thoughts on how you're going to manage that?
I guess I tend to be a bit of a glass half full person anyway, and I think sometimes it does rub people up the wrong way. I think
eternal optimism.
But I do genuinely think that that's what helps me personally get through things, and I think there's so much that we've learned from, and you have to, I believe you have to see opportunities rather than look for the negatives. It's yes, there have been difficult things, but we need to see, well, what are the positives. So for me, that's my mantra, I guess. What are the opportunities, and what can we continue to do that we've been doing, that's been good, that will make things even better. I guess that's what gets me through each day in life generally, looking for the opportunities and grasping them wherever they may be.
Well, I absolutely agree, and let's finish up on that, and using everything that we've learned and taking the good bits and the bad bits to understand the opportunities, and most importantly, do something about it, not move it forward and turn it into action. So that's great. Denise, it's been an absolute pleasure, and if I could just use the opportunity to convey my thanks to you, to the teams that you work with across health and care, and to absolutely state the obvious, we could not have done this without your support. So huge thanks from me, and a definite thank you for being brave enough to have this conversation. Thanks very much, Denise.
Thank you, Caroline. Thank you.